Let's discuss sudden sensorineural hearing loss, or SSNHL, a condition that can be both challenging to diagnose and manage. SSNHL is defined as a rapid loss of hearing, typically within 72 hours, involving a decline of at least 30 decibels across 3 contiguous frequencies on an audiogram. It usually affects one ear and may be associated with tinnitus, aural fullness, or vertigo. The exact mechanism remains unclear, but several theories exist. Viral infections, such as reactivation of latent viruses like herpes simplex virus, could damage the cochlear nerve. Vascular compromise, where reduced blood supply to the cochlea may cause ischemia, given its high metabolic demand. Autoimmune factors, where autoimmune conditions may target inner ear antigens, leading to inflammation. And idiopathic cases, where despite investigations, up to 90% of SSNHL cases are labeled idiopathic. SSNHL may be classified into idiopathic or secondary causes. Secondary causes include viral infections like mumps and cytomegalovirus, trauma such as temporal bone fractures, ototoxic drugs like aminoglycosides, neoplasms like vestibular schwannoma, autoimmune inner ear diseases, Meniere's disease, and vascular disorders like stroke or vasculitis. Diagnosing SSNHL requires a detailed clinical and audiological evaluation. First, take a history noting the rapid onset, associated symptoms like vertigo, tinnitus, or ear pain, and any recent viral illnesses or trauma. Audiometry, specifically pure tone audiometry, confirms a sensorineural loss, while speech discrimination testing helps assess the severity. Imaging, particularly MRI with gadolinium contrast, is the gold standard to rule out retrocochlear pathologies like vestibular schwannoma. Blood tests are sometimes ordered to rule out autoimmune or infectious causes. The cornerstone of SSNHL treatment is prompt and aggressive therapy to maximize the chances of recovery. Oral steroids are the first-line treatment, with prednisone or methylprednisolone typically prescribed at a dose of 1 mg per kilogram per day for 7 to 14 days, followed by a taper. Steroids reduce inflammation and may mitigate immune-mediated damage to the cochlea. Intratympanic administration is an option for patients with contraindications to oral steroids or those who don't respond to initial systemic steroids. This method involves injecting steroids like dexamethasone directly into the middle ear, allowing high cochlear concentrations with minimal systemic absorption. Hyperbaric oxygen therapy delivers 100% oxygen at increased atmospheric pressure, promoting cochlear oxygenation and recovery in ischemic cases. It's typically used as an adjunct to steroid therapy and is most effective when initiated within 14 days of onset. Other treatments may include antiviral therapy for suspected viral causes, vasodilators or rheological agents to improve cochlear blood flow, antioxidants like N-acetylcysteine to protect against oxidative damage to cochlear hair cells, and cochlear implants for severe or permanent hearing loss. Prognosis depends on factors like age, initial severity, and time to treatment initiation. Approximately 30 to 70% of patients experience partial or complete recovery, with better outcomes in those treated within 2 weeks of onset. Sudden sensorineural hearing loss is a medical emergency that requires prompt diagnosis and treatment. Oral steroids remain the mainstay, while intratympanic steroids and hyperbaric oxygen therapy are valuable adjuncts. As clinicians, understanding its multifactorial nature and available treatment options can significantly impact patient outcomes. Thank you for listening. I hope this overview helps deepen your understanding of SSNHL and its management.